good morning, good afternoon, depending on where you are today. My name is CAHMI with the National Center for Health and Public Housing. Welcome to the third session of the SDOH Screening Tools for Public Housing Residence Learning Collaborative. Thanks again for you all making the time to attend. Today, we're going to discuss implementing a screening process with families in mind, thinking holistically about collecting and addressing the social needs of patients and children. And we have a really great guest speaker, Dr. Christina Bethell, who's here with us today from Johns Hopkins University to help lead that discussion. So in case this is the first time you're joining us, or if you're viewing a recording of this session, just would like to let you know some background on the National Center for Health and Public Housing. We provide training and technical assistance to health centers that are located in or immediately accessible to public housing. With funding and support from the Health Resources and Services Administration, we're able to work directly with housing authorities and health centers and other organizations to help improve access, quality of care, address health equity, and ultimately help improve health outcomes for public housing residents. Just a note, though, the views and the comments that we are expressing today represent our own views. They don't represent the views of HRSA, HHS, or the federal government. Just some quick housekeeping items. We would like for this to be an engaging and welcoming and informal session. So if you feel comfortable, please feel free to turn your video on. Last session, we had some really great engagement between Jolie from AAPCHO and all of you all participating today. And so we really hope that that continues. You are muted right now. We'll open that up during Q&A so you can ask questions freely, but please turn your mic on only when you're speaking. And in the meantime, if you would like to be unmuted, just use the raise hand icon and we will unmute you. We are recording the session, and the slides and the recording will be posted to Moodle and will be sent by email. And I did send out the slides and the recording for last week. So if you didn't get that, just let me know and I can send it again. Again, the chat is open. We encourage you to use that throughout the session. So while you're listening to the content, add your thoughts and your questions as they come to you so that when we get to the Q&A portion, it'll be ready. And if you see something on the chat, please by all means respond. Please feel free to share your own experiences and challenges with us and your strategies. This is a real opportunity for all of us to learn from each other, and your input is incredibly valuable. So please go ahead and introduce yourselves in the chat so that we can all see who's here today. Please enter your name, your health center, your location in the chat, so we can see who you are and send that to everyone. Just a reminder about Moodle for resources logging in. I know we've had some trouble with some folks trying to log into Moodle. I apologize for that. We're working to address it. Hopefully your access will be restored soon. At this point, you all are very familiar with our team, but again, my name is CAHMI. I'm the Director of Research Policy and Health Promotion here at the National Center. I'm joined by Dr. Abdi Naboya-Rios, who will be helping to moderate today's session. My colleagues, Fide Pineda Sandoval and Chantel Moore, who will be helping with the polling and the chat and any tech challenges. Hi, Danisha. Thanks for joining us today. Also joining is our guest speaker, Dr. Christina Bethell, and I'm going to go ahead and introduce her. So for the past 35 years, Dr. Bethell has built her work and her career around an intentional goal to catalyze healthcare and public health transformation at the policy, systems, and practice level. And this has been driven by an unwavering focus on advancing a whole person, whole family, whole community model of care that engages patients and the public in a transparent and continuously learning and collaborative way. She's a national leader in this arena and is the founding director of the Child and Adolescent Health Measurement Initiative and the National Data Resource Center for Child and Adolescent Health. And that's a project that's supported through HRSA's Maternal and Child Health Bureau. She has initiated and led the collaborative development, validation, and national, state, and local implementation and IT-based reporting of child, family, and community health and health systems performance and outcomes. So it's a great pleasure for us to have her here today. And as you did during the last session, I encourage you to take advantage of this time and ask her any questions about the points that she makes during her presentation.
Great.
So here's our agenda for the day. We do have a little bit of breathing room in our agenda, and we organize this way so that Dr. Bethell can have as much time as possible. So we're going to do just a quick recap of the second session. We're going to provide an overview of today's session, and then Abdeen is going to walk through a case example to help set the tone, provide some context and background for Dr. Bethell's presentation. And then we're going to have Q&A. So just briefly, during our last session, we discussed different ways to determine the best SDOH screening tool for your patient population and needs. And we identified a set of criteria, including what domains are covered in the tool and if those match the common challenges that your patients face, such as financial instability, housing insecurity, food insecurity, the length of the assessment, whether it's short enough to fit into a clinical interaction or whether it's too long for a patient to fill out on their own in the waiting room, whether that places a burden on the patient. We also discussed using a tool with the readability level that fits your patient population, the health literacy levels of your patients, the benefits of having a tool that's been translated into multiple languages that can reflect the diversity of your patients, considering whether there is a cost associated, whether the tool has templates that can be integrated into the EHR platform that you use, whether there's flexibility in the tool, if the questions can be added or modified or omitted based on your health center and patient needs, and what types of resources you may need to have in place in terms of staff capacity, training, and IT infrastructure, and finally, how that tool ranks in comparison to other tools. Our guest speaker, Joe from AAPCHO, gave a really nice overview of the Prepare tool, which is one of the most common standardized screening tools that are used by health centers. And he discussed SDOH data collection strategies using workforce development and health IT infrastructure, using the 5 rights framework that outlines the importance of collecting the right information in the right format, with the right people, using the right channels at the right time, and what all of that means, how to determine the right information, what the options are for collecting the data, which providers are suited to gather that information, the modes for collecting it, and at what stages at a patient's visit are appropriate to gather which pieces of social risk data and needs, as well as the importance of documenting your health center's response to those needs. So please feel free to review those slides and the recordings from the last session to get a refresh on all of the wonderful tips and the strategies that he shared. Today, we are going to, today our discussion is guided by these following questions, focusing more on maternal and child health. So the first is, how can trust be built between patients and providers when addressing patient risks? We talked a little bit about this last time, but we're going to explore it a little bit more today. Question 2, it is important to integrate social needs data into the delivery of healthcare, but how? So how to put it into practice. And then number 3, can screening tools be helpful in the assessment of quality of care? And if so, how? So our learning objectives are a reflection of those guiding questions. So by the end of today's session, hopefully you'll be able to identify ways to build trust between patients and providers when you're identifying and addressing social risks, describe practical ways to integrate data from screening tools and guides with clinical summary reports to prepare for inpatient visits, and then finally discuss methods to measure and assess quality of care based on input from screening tools. So I have a polling question. Since we are, Nope. Sorry, guys, I'm trying to, oh, there it is. Pass this poll. Okay, so since we're switching gears slightly today and we're focusing on maternal health, we wanted to get a sense of what types of pediatric screening tools that you're using at your health center. So Chantel, can you help with this poll?
Sure. What pediatric screening tools are you currently using? Are we using the Ages and Stages questionnaire, the Parents' Evaluation of Developmental Status, Survey of Well-Being of Young Children, Modified Checklist for Autism in Toddlers, the Patient Health Questionnaire or EPDS, Accountable Health Communities, Health Leads Screening Tool, Pediatric ACE Screening and Related Life Event Screener, a Safe Environment for Every Kid questionnaire, or Well Child Care Evaluation Communities, Resources, Advocacy, Referral Education Survey Instrument.
Thank you so much for sharing this information. It really helps. It's helpful for us to hear. It helps us know what you're using. So thank you for that. I'm going to close the poll and share the results.
Okay, so we had 25% of participants said that they used the Ages and Stages questionnaire. 25% of our participants said that they used the Parents' Evaluation of Developmental Status. We had 0% for the Survey of Well-Being of Young Children and 0% for the Modified Checklist of Autism in Toddlers. We had 75% that answered that they used the Patient Health Questionnaire or EPDS. 25% used the Accountable Health Communities tool. 25% used the Health Leads screening tool. And 0% for the Pediatric ACE Screening and Related Life Event Screener. 0% for a Safe Environment for Every Kid questionnaire. And 0% for Well Child Care Evaluations, Community Resources, Advocacy, Referral, and Education Survey Instrument.
Thank you so much, Chantel. And if you all are using a different screener and it's not listed on here, just add it to the chat so that we can see. Thank you so much.
Yeah.
Okay, and now I'm going to pass it to Abdeen.
Thank you, Saki. Let's look at a case study here. Her sister is a 17-year-old who is pregnant and has a 1-year-old child. She has come in for her child's 12-month well child visit. As she has reported, she is having difficulty with her pregnancy and is very afraid for her health and seems to be lacking support. Implications for SDOH screening? Question: how can the screening of the social determinants of health help reduce her risk of adverse pregnancy, as well as support her well-being? Now, looking in general, in terms of science and epidemiology of child development and maternal health, here are some statistics that may be of interest. Fact, over 60% of young children have mothers who do not have excellent or very good health, and nearly 30% of mothers report lacking emotional support. This often prevents healthy attachment, which impacts child brain development and early and lifelong health and well-being of children and families. Now, the implications for SDOH screening. Question is, what does this mean for screening the social determinants of health? Back to you.
Thanks so much, Abdeen. All right, Dr. Bethell.
It's time for me to go. Okay.
Thank
Okay,
you.
great, great. Just get my slides up. Okay, so thank you for having me here today. I'm excited to present to you and hope that it's helpful. I know somebody's monitoring the chat, and I just want to make sure that you send some kind of flag up to me, even if you have to interrupt and speak. Oops, sorry, so that I know if there's key questions as we go, if that's okay. So can everyone hear me well? Okay, great. So I'm going to be talking about a model that we've been working on with HRSA and others, the American Academy of Pediatrics, lots of family organizations for quite a long time, called the cycle of engagement. And it really is based on the idea that we need to engage families in a continuous process in order to build trust, to screen for the whole health of the child and family, and engage them in what needs to be done to mitigate risk, prevent risks, and address risks. So first, I want to just say, if you haven't heard of the CAHMI, we focus a lot on data and measurement in action, because without data and measurement tools that are valid, we can't really get the information we need. But then as soon as we do, what we need to do is effective engagement and then promoting flourishing. So our work is across those four main areas. And some of you may know us as having developed a lot of the metrics that are in the national surveys, but also then moving on to disseminate that data in a point and click way for everyone in the country to be able to get their micro data findings at the state level, regional level, and national level for all kinds of variables in the National Survey of Children's Health. And also, again, the work we're trying to do to advance a relational focus, which we know the science of child development is very much based on safe, stable, nurturing relationships, and helping families not only with economically associated social determinants of health, but also the relational health factors that are so key. But I'm going to focus mostly on how do we implement Bright Futures guidelines, which are guidelines supported by HRSA. And in the Public Health Service Act, Section 2173 of the Public Health Service Act requires all non-grandfathered in, I don't know quite what that means at this point, health plans and health insurance issuers, of which you are a part, to cover the services and screenings listed in the current Bright Futures periodicity schedule for plan years beginning December 28th, 2021. It's actually been recommended by AAP and by many, and all through the Accountable Health Act for a long time, but they're making it a stronger requirement. And based on what you all reported about screenings, you're required to do developmental screening. And it looks like some of you may not be in the habit of doing that, as well as maternal depression screening. And I'll be sharing a little bit more with you what these guidelines are, and then more about how the cycle of engagement might be able to support that. And I'm hearing something in the background, just so you know. I don't think it's, yes, news, somebody's news is on. Okay, great, thank you. So first thing is that we have a lot of transformation efforts going on in the country. HRSA is very much a part of it with Title V, as well as Medicaid and all the health plans, to really, again, focus on these Bright Futures guidelines, which have been around for a long time, leverage the well child visit as a place where children and families go early and often, especially before school, and then use what we get to really enter children into tiered levels of support with care coordination, case management, and other wraparound services that are needed, that are often community-based. And this sits on a sort of dire situation, which I see as an opportunity, that we have tremendous opportunities, because we know that when we do improve, good things happen for children and families. But at the moment, about 9 in 10 children don't receive all of just a minimal core set of those Bright Futures guidelines required care, whether it's screening, anticipatory guidance, family-centered care, or referrals and follow-ups for the issues they have. But after decades of work, we've invested so much in getting even developmental screening done, let alone followed up, which is worse. So even when we do screen, usually there's no follow-up. And even when there's follow-up, families often don't go. And a lot of that has to do with trust and the relationship with the families, to really follow it all the way through to the point where they're getting support and feel like it's helping them, because that's why they drop out, either lack of trust or because it's just not seen as helping, or it's too hard. The services are too hard to get to, or they're not culturally appropriate. And inevitably, what ends up happening is families are not coming in for recommended visits, even in areas where those services are widely available. And that's a loss of income, for one thing, because they're paid for completely by all health insurance plans by law. But the other is, it speaks to us about what we need to be doing to show value to families and get them in before they end up in the emergency room or the child enters school with so many problems, which is usually what happens now. So one can imagine why we're not implementing these guidelines. If you just look at this little table, it basically outlines throughout infancy, early childhood, middle, and adolescent years what the different things are recommended. And that's a lot of information for any provider to remember, especially if they provide services across all these age groups. There's some supports and worksheets that can happen, but you have to have one for every single age. And if you look at this, it's up to 21 with breaks every year from 5 to 21. And then for early childhood, about 12 to 15 visits. So that's a lot. And it is one of the reasons why we are not seeing the implementation of these in guidelines, but every single piece of it is important. If you look at it, you might say, yep, I need to do that. I need to do that. How do we do this in a way that's not only family-centered, but also provider-centered, that's possible to do. We have a lot of moral injury going on out there. People who are working so hard in clinics, doing their best and knowing that they're not able to do things and lacking the tools to do that way. So this is just a little bit of a picture of what some of the different pieces are. I'm going to be focusing on the pieces that you really need to talk to families about. So all of the physical screens, you can't really ask a family if they had a newborn blood test or a bilirubin test. They're not reliable reporters of that, but those things are actually pretty easy to find in your administrative data. And often you do have to report those things to CMS. What's really you cannot get from that reliably is whether certain types of anticipatory guidance and screening were done and whether families have different risks and strengths. So just for the anticipatory guidance topics, it's 28 to 32 topics for each age. And so how do you find out what families really need to talk about? Because the guidelines are what are you to meet families' anticipatory guidance priorities, not to talk about 32 things. But how do you find that out in a way that allows you to prep for your visits and not just find out the second that they come in, or maybe try to get it in the visit verbally, which could take up all of the time you have. So these are issues that really block implementation. And then I think there's just questions that people have of, do we really need to know all this? These are just a summary of the social determinants of health that cut across 8 different prominent measures. And as you can see, you're all using different things. But if you take them all together, they basically represent these 10 categories of issues that are in social determinants of health conceptually. Housing, food, financial strain, discrimination, social isolation, addiction issues, exposure to violence, stress, toxic stress in particular, parent personal well-being and parent-child relationships. They're all in the various tools. And if you look at this resource on the Kaiser Permanente website, they list all of these. The Accountable Health Communities is the one that CMS has put out individually, and it includes all of these factors in this table right here. And we've actually created a national index using the National Survey of Children's Health to look at all of these social and relational determinants and look at those 2 factors separately to see if they are distinct, so that we don't just measure food insecurity and housing instability, but we take into account other factors that it could be from the science even more impactful, or when they're combined with economic hardship might really pack the biggest punch. And that has things to do with interpersonal safety in the home, adverse childhood experiences, mother's mental health, and so on. So when we looked at this, what we found looking at all of these risks was that about 46% of all children on Medicaid had risks in 2 or more of these domains, meaning they already had a developmental delay, a special healthcare need, fair or poor health status, which is a very, very high bar, meaning those children are really not well. And some of these social health risks, which are all very distinct from a statistical point of view. So food insecurity and insufficiency is different than the having an unsafe neighborhood or treated unfairly due to race, racial discrimination, which we know is a public health issue. And so we tested that to find out how could we get a minimal index that was most mapped to some of the social determinants. And I'm showing you this just to basically make the point that it is important that we persist in trying to assess and bring information about social and relational determinants of health into our care. What we found, and then I'm going to go right into the tool that I want to present that might be supportive, or the model that you could consider using, is that children who had more, of course, social risks or relational risks were much more likely to have an mental, emotional, or behavioral problem, which is almost an epidemic in many ways. So what you can see here is that children who have none of those social risks or relational risks, about 15.3 have a mental, emotional, behavioral problem. Those who have 2 or more of the relational health risks, like having 2 or more ACEs, which is a high bar, or having parents who are not in excellent or very good mental health, about 45% almost, which is a very big climb. And that's it when they have no social health risks. When you add the social health risk into that, it's 61% having a mental, emotional, or behavioral problem. Starting at age 3, we can measure this. So this is a very big deal. And often the populations that are enrolled in Medicaid are the most vulnerable. And so you can see that it is not a small proportion, and that about 60% of children who have relational health risks do not also have those economically associated social health risks. So they don't have food insecurity, housing instability, but they do have two or more ACEs or mothers who are not in good health. And when we look at the punch that packs, it is actually the highest impact is the relational health factors. And that's why a lot of the social determinants measures combine both relational factors and social factors. But if you combine them completely and don't treat them distinctly, you might be missing things. So that's why, you know, we want a whole child, whole family perspective. So back in the 90s, early mid to mid 90s, we started looking at tools to engage families. My work has always been on family engagement based tools to create personalized care and monitor quality and improve the things that only families and communities can address, and how the health system can factor into that. So we created the cycle of engagement in a national process with many others to engage and support parents to promote the health and well-being of their children, facilitate early identification of issues, foster trusting relationships, promote positive child and family health, and not just be disease-oriented, but to proactively promote well-being and resilience and social and emotional well-being, and also provide pediatric practices and healthcare providers with real-time and continuous feedback about their quality, and it helped them really actually implement guidelines rather than just throwing them at them in a 5-inch book that you can't possibly decipher. If you have the Bright Futures book, it's about, it might not be 5 inches, but it's definitely like 4.5. So what is the cycle of engagement? The first thing is it's a personalized mutual engagement model that really values both the provider's need for information and the family's need to provide that, and that trust building in relationship. It's a family-centered integrated approach. So you don't just get a separate form, like here's a maternal depression screen, here's a developmental screen, here's a social determinant screen, here's a psychosocial screen. Oh, and here's a list of priorities you can check, and they're all separated. Nobody can make sense of it, and then you're just scrambling. Even if you have it in the electronic record, it's in different places. It's not creating a story of the whole family, and that's a problem that we've heard. We also have done studies showing that most families who have developmental screening don't even realize that's what happened, or maternal depression screening. They don't know that's what you're doing because they hardly ever get feedback unless it's a dire situation. And even then they often don't get feedback. So screening without dialogue and shared decision-making kind of doesn't fulfill the purpose, and it can be demoralizing for the provider as well, where you're collecting data and you know you're not doing anything with it, or you just couldn't and you tried. So how can we get out from under that? It's also a measurement process that can provide continuous data on your population and give repeated feedback over time. A child can become a child with special needs or a developmental problem, or a family with social determinants at any time, week by week, literally. Lots changing in families. If you only measure it once, it's really, really not going to give you what you need. How do we do it continuously without basically tipping the boat? And then, of course, because the tool I'm going to share with you gives you population-based data for all the families who've completed this tool, you can use that to get a picture of how many families have each of those risks over time. And that can help you advocate for resources and services, as well as help build the partnerships that you need with the community-based organizations that can provide those supports, and other agencies as well, whether it be child welfare or Head Start, early Head Start. They are all actually held accountable for child development, just like healthcare providers, and working together, McV with home visiting. All of these agencies have roles to play and often don't work together the way that they could, and lacking data about what's needed is often what drives that. So this is a visual I'm not going to go through completely, but the bottom line is that the cycle of engagement for young children and well visits includes completing a well visit planner before the visit for the family, and then creating a personalized connected encounter during the visit, And then after, as you like, you can implement the online Promoting Healthy Development Survey, which is, we developed it at the same time as we developed the CAP survey for kids, which our group developed and got into NCQA and HEDIS. We had the Promoting Healthy Development Survey as well validated, but they weren't interested in adopting just an early childhood quality measure, but it has been adopted by the National Quality Forum and is perfectly aligned with Bright Futures guidelines. And I'll tell you a little bit more about that. So it's available for you to use and gives you automated feedback reports on quality after every 25 families completes it. So you can use it for quality improvement and find out if what you're doing, whether it be the well-visit planner or some other tools, actually working for you to meet those guidelines, Bright Futures guidelines. And this all together really seeks to advance family engagement at all 4 levels of basically improving communication and building trust, family involvement and shared decision-making and plans of care, so that you don't just tell families what to do, but they've bought in and they're really going to get the support that you try to give them, as well as ask for what they need. Also, the data at a population level helps families really collaborate with the organizations and systems for improvement and engage and improve the health and well-being of all children. We've been at this a long time, if anybody wants to see the history, but we literally started in 1996 and have engaged a lot of different organizations that are on this slide, including 12 different Medicaid programs, of course, the national survey, Head Start, different groups. And yet most of this has been through research processes, and we didn't get the support we needed to scale. Even though HRSA funded us, they didn't fund for implementation, which is the oldest story in the book. Come up with something good and then you can't get it out the door. So we're now rebooting, and we are able to offer this now for closer partnerships, and especially for community health centers. And for the people on this call, that is our primary audience. It's in English and Spanish, so that helps a lot. And most of our work and studies have been done with families that are lower income and also non-English speaking. So this work is actually named in a lot of national projects, like the California Roadmap to Resilience on ACEs screening are recommending the Well-Visit Planner, definitely Title V and Medicaid in their resource book, and home visiting. And also we've had use of this in Mexico in particular, especially in communities that don't have a lot of providers, where they're engaging grandparents even to basically use the mobile optimized version, learn about child development, and come together in groups in a community health worker model to help educate each other and really start advocating for resources. And there's a lot of value in using this in a group health or a group well visit context. So the value has been shown in our randomized trial as well as quasi-experimental, and we will continue to do research. We've seen value for improving that priorities are being addressed for families, which is number 1. Time is actually freed up in encounters to really focus on issues, and there's higher satisfaction in the visits for both the providers and the teams, who feel like they're now working together on behalf of the family because they can share the agenda. Reductions in urgent care use, and also improvements in I mentioned team joy, effectiveness, and efficiency. Family experiences have been routinely high. It's always been like around 92, which is mysterious. This is just an example of the tool being used in a kiosk in a community health center in Los Angeles. So I can share these slides with you if you want to know more, and I'm not going to go through this, but this is just summarizing more detail about the studies. In terms of alignment, I'm also not going to say too much about this, but I do want you to know that beginning in 2024, those state Medicaid core set measures are not going to be optional anymore. They're going to be required. And they include a lot of measures that relate to preventive care for children. And so we've aligned specifically to make sure that whatever this tool includes, this non-proprietary tool that can be used, aligns with the guidelines. So for example, the Well-Visit Planner and PHDS together align with 7 of the 19 HEDIS measures for child, adolescent, and maternal health, 2 of the 4 measures on child preventive care, and 4 out of the 8 or half of all the Medicaid core set measures. So using this helps you promote that. So it's going to be mandatory reporting soon. And then also, if you know those who are doing home visiting, Head Start, or trying to get certified by AAP for doing Bright Futures, which a lot of providers want to do, there's also a close alignment there. I wanted to make sure you know that the Survey of Wellbeing of Young Children is the developmental surveillance and screening tool used. It was developed specifically as a non-proprietary tool compared to the ASQ and the PEDS, which we both two sites use today. I just put this out so that I could prove it to you that it's named specifically in Bright Futures as qualifying for developmental screening. It's published in a JAMA paper, how it compares to ASQ and PEDS, and it is a tool that is free, so you don't have to buy it. And that's been one of the issues for any tool like this, is that we couldn't put the ASQ in because you have to buy it and you get charged on a per child use. So I wanted to make sure that you knew that. However, if you want to keep using the ASQ and PEDS, you can add a link to the Well Visit Planner, which is an online tool, and you can send families to that if you want to continue to use it. So let me just do a quick run through of what this looks like, and it'll go pretty quick, but I want to give you a landscape and you can decide to learn more. So the 3 steps are to engage families, partner with them during visits, and then seek to improve. And there's 2 family websites, a Well Visit Planner website and a PHDS website, and families get a report after completing it. It takes 10 minutes to do the Well Visit Planner. They get a visit guide. That gets sent to you through a data dashboard that you can access at any time and download the visit guide for the family. The PHDS is online and the family gets a feedback report, and after 25 completions, anybody using it can download a quality report and see how they're doing. And so you sign up and have a dashboard, and that's how you get your information from families and all the implementation resources. And then the families just go to your unique URL. So you get a unique website with your logo on it, a URL that you can create the code name for. And so it looks like it's yours, and your families are like, wow, when did you build a website? But it's actually through our system. And so for the families, we basically give them some basic information. But again, I've mentioned already that it's 10 minutes. It helps families be confident that they learn. A lot of families do not know about child development. They don't know why they're going in for a well visit. They think it's only to be weighed and get immunized. They have no idea. And this is really important because most of the guidelines are about supporting the family and the child, the relationship, addressing social determinants, because these are the factors that drive healthy child development more than anything. And the other things are finding problems. This is about promoting development. It's true preventive care, health promotion. That is the call of Bright Futures. That is what you're being asked to do. And then to use that information during the well visit to go right to the risks, right to the issues, right to the priorities of the family, and to spending some time on the active promotion of well-being, even for families and children without risk. We need to be at it because they fall in and out of risk a lot. And then, of course, the online promoting healthy development survey you can use as often as you want. Ask one family to do it and another not, or just do it 1 month out of every year, or whatever you want, but it gives you that feedback and it's up to you. So this is just a look of what the family website looks like. You can add a little voice recording. It's not quite ready yet, but we're adding features all the time where you can welcome your families personally. They go on and get a visit guide. And then these are the topics, and they're aligned perfectly with Bright Futures, but you can also add other assessments like child flourishing and family resilience, a set of parent-child emotional connection tools, and other things like that. And this is what the dashboard looks like, where you go to get the Well Visit Planner data. You can get a clinical summary, which I'll show you in a minute, or a well visit guide, which I just showed you. And then you can identify the child that you want to pull up the visit guides with if you already know their information. So this is what your clinical summary would look like. And this has all been integrated fully into the EHR, which is not a problem if you have receptor sites for it. It's really about whether you have a place for the data to go. All of our studies were full EHR integrated. The issue is that the data gets spread out all over your chart and it's not put together into a story in one place. So even if you integrate it because you feel like you need to for record keeping, it's not necessarily going to help you as much in the visit. Okay, so in the actual encounter, you might want to see a whole child, whole family view, which is what this clinical summary gives you. But it's not hard to integrate it into electronic records. It's really on the side of your electronic record system of whether it has a spot to receive this data. But the features are, there's 5 sections about this child maps perfectly to Bright Futures, including general health and updates, strengths to celebrate, screening and assessments, and caregiver anticipatory guidance priorities. Among all those 30 or so, they pick up to 5. And we did a study letting them pick all 32, and no family picked more than 5. And the average number is 3. So families are not blowing up the visit time at all. And they get information as they go. So they might learn about factual things and get worksheets and things, so they don't need to talk to you about it because they learned how to install a car seat by accessing resources online. And there's a definitions key at the top and additional resources. We've created these little flows that could maybe be a way to think about how you would do a visit differently with all of this, which is to start by celebrating joys and strengths, even children with lots of risks. There's all kinds of positive things, and we point that out to you in the clinical summary. Be sure to ask families, do they think we have a concern, even if you see a risk, to engage them? Do they think that we need to act? Do they have resources that they have already known about? Maybe they've seen another provider, knew about this and didn't use it. So continuing to make it very focused on a family relationship, continuously promoting possibilities, which we know are unstoppable and often not tapped into. And using motivational interviewing, and this is just a mnemonic. I know you're going to be talking about motivational interviewing or have already. This is just a mnemonic that AAP has put out for how to talk with families about potentially difficult conversations whenever you're talking about risks or just really anything, relationships in the home. So those are resources as well. In terms of the PHDS, you also get a report. Again, this has been used nationally in many ways. It's a pretty extensive report for providers that after every 25 visits you can get, and it looks at these aspects of quality: anticipatory guidance in parental education, whether families talked about something or didn't talk about it, but it was okay. If families say, no, we didn't talk about it, but I wish we had, or yes, we talked about it and I didn't get my questions answered, then it's actually an area for improvement. So it's a very, very generous measure set for providers. It's easy. We make it easy for you to get good scores, but it's just for you. So it's not from your health plan. Your health plan could use this if they wanted, but this is so you get feedback in a real-time way. And then you have a dashboard and you can go in and generate your report, and we give you a notification saying you have a report ready. And so that's kind of how that works. Implementation uses the EPIS model, evidence-based EPIS model, with different phases of explore and plan, which are the most important, because once you do that, you can really implement. And it's very important to go through those steps. And these are just postcard examples. You can tailor, put your own logo in on, you could hand a family to get them to use it, QR codes, and then different workflows. So this is just an example of how this has been promoted through Family Voices, as well as the early Head Start and Early Head Start and AAP and others. But we are mean and lean. We do not operate on tons of money at all, but we are here to partner with you. And I'm curious if anybody's interested in trying it out, using it, let me know. And we hope that the next year will really be communities of practice, and anybody who wants to use it now, though, is welcome to, as long as you give us feedback. That's all we ask right now. Okay, that's it.
Thank you so much, Dr. Bethell, for that all of that great information. We are going to open it up to Q&A. Let me share my screen. Does anybody have any questions? Just raise your hand or put it in the chat, and we will unmute you. Or okay, it looks like Lisa has a question. Vida, do you want to handle this?
Yep, let me unmute her right now. Lisa, you should be unmuted right now.
Oh, okay. Hi. It's more of a comment, not more of a question. Great information. And I think it will definitely benefit our clinic here, as we are actually trying to enhance the process with pediatrics here, and finding new ways to keep our patients engaged even more.
Right.
So I think this is something that will really benefit our clinic. So I will definitely bring this up to my superiors and share this information with them. So I just wanted to say thank you, and I think it will be great for our pediatrics.
And Lisa, if you're interested sooner or later to sort of have a say in some of this, we're updating everything right now and doing the Spanish translation and all the materials translations, and we're working closely with Family Voices and others. So if you're interested at all in reviewing a few things and giving feedback, like that flyer I think would work, I think you should change it that way, I'd be very interested in hearing from you. I don't know what part of the country you're in, but we try to provide materials for families in different dialects and different culturally appropriate ways. And so keep us posted.
Yeah, absolutely. Yeah, that would be great. In our community, in our clinic is basically almost 80-90% Spanish speaking.
Yeah.
We, obviously we do have other languages as well. But that's the main one. So I think it will be really great.
Yeah, and what I can share with you is that we've had a lot of testing with sort of new to the country, even Spanish speaking families who don't know about WellCare and are not necessarily trusting. And so Head Start, Early Head Start, WIC, other programs like that are actually using the Well Visit Planner to educate families about why they might want a primary care doctor and about how it is for them and how it is for you and your family. And it educates them as well as gives them, and then they have to sign them up for a medical home, as you know, within 30 days.
Yeah.
And so home visitors, WIC, and Head Start can be the source point for starting this.
Yeah.
As a way to get families even in, because you're not seeing a lot. You may see, you can use it with the families who come to you, but a lot of families aren't coming.
Yeah.
And we're really missing them. So, yeah.
Absolutely. Thank you so much.
Mm-hmm.
All right, thank you so much. So right now we don't have any additional questions, but everybody's more than welcome to participate.
Mm-hmm.
Um,
I mean, obviously the model, if you're not providing a lot of pediatric preventive care, is that true for some of you? You're just not, either personally or your center doesn't really focus on that so much. Is that the case? Somebody mentioned like if you personally don't ever see kids or families, this might not be as relevant, but the concept, keep in mind the cycle of engagement is a concept, okay? I presented to you a tool set that we've created for the early childhood well visit for that model, but the model itself is similar, which is something to engage them in an integrated approach to assessment and priority setting. So that's the family agenda. And then be able to have that information in a way that creates that personalized connected encounter, which is really important because so many times we spend all the time just assessing and not really helping. And then when we help, they don't go because that's relationship dependent. And then of course the quality feedback. So there's other tools that you could plug and play into that model for other populations. So wanted to make sure I clarified that.
all right, so we have a raised hand from Denisha Reed. Denisha, you're unmuted.
Hey, I
Hi.
wanted to share with you all some of the things that we're doing at our health center to engage pediatric patients and their families. I personally don't work with pediatric patients fully here exclusively. I kind of do more so community-based things for COVID and food access, but one of our pediatricians, she's really, really passionate about reading and making sure that our children have, the appropriate literacy levels when they go off to school or as they develop throughout school. So we give away books at our well child visits to help engage students and parents and entice the whole family to come for their annual well childs and things like that. And a lot of like lobby education on immunization. So that way, while they're there, we're connecting, we're talking, we're doing a lot of health education within the health center, again, to build relationships. So they know everybody in the health center, not just the pediatrician or not just the nurse, but from our WIC office,
Everyone,
to registration, all that good stuff.
Great.
So reading has been one of the biggest things that we have been doing here, as well as because we're right outside of Algale Gardens and Philip Murray Homes here in Chicago.
Right.
And so within Algale Gardens, which is the housing, Chicago Housing Authority, they work with Metropolitan Family Services, which is like a full service social service agency. So they do a lot of the social service work and we do a lot of healthcare, but our way to kind of integrate that has been the books and literacy and just trying to think of other things that we can do to engage, like you said, like the whole entire family or really kind of get them connected or reconnected when they have that, entry point of care.
Well, I'd love to comment on that if that's okay. First of all, congratulations for picking reading, because it's like, it's not only important for brain development, it's also important for bonding. And it's also beneficial to the parent. So we often think of what parents need to do for their children, but parents spending time with their children like that actually benefit and reduce stress for the parent and the family. So it's good for everyone. And I wanted to make sure you knew that the the Well Visit Planner tool in particular is something families drive, like they can go online and use it and get their own and get a family account. So they really can decide to just use the public use site and own their own data. For example, like in communities, like if you had a public housing area, they could decide to get an account and basically have their families use it, or a church or something, and then be the keeper of the data, where they then can go to the health systems or whatever and say, we've got families with these needs. And then the individual families being able to learn about child development, which is often a big gap, or having dads do it, because we've got a lot of fathers who like an online tool where they can learn about things, or grandparents can fill it out. So you can have a grandparent, a mom and a dad, and maybe an aunt fill it out, and they all have a different view of the child and how they're doing. So it's a family, it's also can serve as a family engagement tool, like literally for the family to take a look at how they think things are going and what their priorities and needs are, and then comparing that. So I just wanted to point out. Yeah.
Oh yeah, no, I had a question. What one of the things that we're facing here, and I'm pretty sure other health centers can attest to this too, is competing with social media influences, or people getting a bulk of their information on how to do a lot of things from social media. And so I guess just in anyone, this can be a conversation starter, but I guess what type of initiatives or interventions or anything that would address, I guess, bridging the gap, or using social media more, even to like, roll out this interface, right?
Yeah.
I just think that there's a lot of things that parents, grandparents, everyone's kind of gravitating to as a second, third, or fourth opinion, or even bringing to the doctor's visits, right? And saying that, my kid saw this, so I'm interested in that, or how do you feel about this, right?
That's right.
So kind of using that for empowerment and education.
Exactly. That's really a lot of the vision. And of course, that means partnering with you, right? Because that's where that was going to happen, but supporting you, it'd be great to look at that. And also what's nice about this is that it is based on guidelines, so the providers can really trust it. In other words, I can't put anything in this tool that hasn't been blessed, and also tested with families, so that it's hard, like to figure out how to ask a question of a family about something that's in a medical guideline. And so I think that it has a little bit of advantage in being able to say that it's recommended by the American Academy of Pediatrics in terms of the guidelines, but it's family friendly. I would love to learn from you whether you thought it could be valuable, because anybody can pick it up and start the conversation, is like you said. And maybe you have more ideas about that, but I'd love to hear, because you get a link and a QR code, which you can just share with your families. And then they can just click on it and use it, and it'll go where you need it to go, which makes it very amenable to those platforms. What are you thinking, Denisha?
Oh no, I'm just thinking that, just like again, this is, so when I did work with children and families, mostly it was like for pediatric asthma management. So a lot of AAPs and ACTs and things of that nature, and just teaching children and their parents how to monitor asthma symptoms, especially for those who, in ER reduction and all this kind of stuff.
Yeah.
But a lot of the tools and the way that especially a lot of younger parents find out information is from, social media and whatnot. Like they have screenshots and bookmarks and all kind of stuff. Like that's where they gravitate to get information. And then they kind of come to the doctor secondary, or come to the nurse or their case managers or whatever with all this information. So for me, I guess I'm just trying to work backwards, where we as a health centers, or we as the institutions and the research places, like big up our social media. And I know that's a challenge in itself, for even partnering with influential people on there to get them to like advocate and use and sponsor and support these things to kind of bridge the gap. Because you can say this is approved by American Academy of Pediatrics, but that doesn't mean anything to someone that's 22 with 3 kids. A lot of times it just doesn't, you know what I'm saying? And so a lot of times it's a matter of like, how can we make this stuff relevant to them, so where they'll want to use it, where it is meaningful. And so it's not like, even though it's like empowered and it's family friendly, what is some of the ways that we can make it more receptive to them?
And that's the goal of our work. So if you were interested and we could, maybe border you in some way, that would be great. It was developed with families. I don't move a muscle without families. So we know that once they see it, it's like, oh, how come I didn't know that about this? But getting them to see it and respond is the biggest challenge, for sure, like you said. So how to do that well. But
And
it is for
sometimes-
them. Yeah, go ahead.
Yeah,
Sorry.
and sometimes, you know, the social media influencers do carry a lot of weight, but so do people in the community and carrying the message from the community. So if getting those stories about people who have engaged in the planner and it has actual families who used it, have found benefit in it, have learned something, and then sharing that story with their neighbors, with their members in the community can also be really valuable.
And it's also something we're looking at definitely to address equity issues and also structural racism, in the sense that the data that's produced out of it can really look at disparities and if a community organization wants to sponsor this, they can get that aggregate data and see what's happening and bring that information to the health system and say, here's what's going on right now, and we need to address this. And so having ownership of your own data is a big deal. And this is not a take from families. It's definitely an engagement partnership where they get their data too. It's not like, and they actually can decide not to share it with their providers. So it's kind of, they're up to them. So you could just use it and not share it with your provider, and then you're the one that just comes in empowered, or you can make it a mutual thing if you're at that place. So that kind of empowerment of families and communities is really a key. It's a second way to do it, right? Like we've even talked about churches that have the trust of families, but a lot of young families that aren't getting the support they need, and helping them through something like this, learn about what they should be getting, and also engaging them to get the support. Yeah.
Great, thank you so much. I'm looking at the time. Does anybody
Yeah.
else have a question that they would like to ask?
What about health facilities that have different communities speaking different language, like Avid speaking, Russian speaking, Swahili,
so here's
Swahili,
all we need are partners. When we get a partner that needs it in that translation, that's how you do it. Like we wouldn't do it outside of a partnership to make sure it actually worked in a place. And so we've had requests for Swahili, Chinese, and Russian a lot. I have some other tools because I developed a lot of measures, and they're like in 20 languages or something around the globe now. And so we just would partner as the need arises. Right now it's in English and Spanish for obviously reasons. We picked those two. But there have been people who want to have it in different languages, and then it's just a matter of hooking up and actually doing that translation, making sure it's resourced properly, and then built on the back end, which is mostly just like, it may seem obvious, but you have to put it into it. You have to put the translated information into a database so that when it gets queried, it shows up. So it's easy process, but it is a process and can be done for sure. And especially as the need happens, like there are people out there, different foundations that would be willing to support that. I think if it was brought to their attention, because really, honestly, it's mobile optimized. There are people all over the globe. Families do not understand child development. And so the tools operate to educate families about child development, and also to help them reflect on their strengths and to bring hope. It's not just about what's wrong. It's about what's already right. There's always something going well. And also giving the message that the system is there, supposed to be meeting your needs, but you have to reflect on what those are. And even being reflective, being asked about your own well-being is not something a lot of families have ever experienced. I mean, we've had families in focus groups cry. They're like, nobody has ever asked me about anything like this. And so just being heard, there's a way that filling it out makes you feel heard and seen, especially if you know somebody's gonna actually look at what you're saying and meet you there. So I'd love to keep in touch with anybody who's interested at any level. You're really where the rubber hits the road from my point of view. And the main kind of frontline folks we had in mind in developing this as long ago as we did with HRSA and MCHB and all of our other friends.
Thank you. We have one more hand raised. If you
Okay.
can hang on for just a couple more minutes, Amelia.
Yes, I promise to be really quick. I just wanted to.
I'm having trouble hearing you.
Hold on, let me. Can you hear me better now?
Oh, yeah.
Okay, great. So I promise I'll be really quick. I was just going to mention that we do have some clients who are deaf and hard of hearing. So thinking about languages, an easy little thing, if you don't have like a large population of that, before partnership, easy little things are just adding captions to any videos that you have to make it more accessible, which also works in terms of like people who are just elderly and they just can't hear as well. So then the captions will help them out as well to reach kind of the elder generations in part of the family to keep them included.
Oh, that's great. Yeah. And grandparents, by the way, love filling it out because then they can take it to their kids and go, I've noticed these things. We've at least had that happen quite a few times where it's the aunt or the grandparent and then they bring it up. But that is actually really great because we are getting ready with all the new upgrades we're doing to the look to do new videos. And we haven't done one in a while. And so having the captions is really key. And you know, it's just a matter of resources, but over time it could also be for people who, yeah, anyway, we can talk into different issues around managing disability access, but it's on our mind. Okay, so I think we're out of time, but I sure have enjoyed talking with you and hope that we have a chance to connect again in some way as you like.
Yeah, so thank you for joining us.
Do
and,
you want me to leave while you do this?
Oh, no, it's up to
Okay.
you. Yeah,
Okay.
thank you so much for joining us today. Just a couple of quick reminders. I know people have to hop off. You see the evaluation poll, please fill that out. Also in the chat to organizer, any aspects of this that you found most useful, please let us know what could be improved. Any other topics that you'd like to include further sessions, please do that. Just a quick reminder that our next session is going to be on the 1st. We're going to be joined by Dr. Zara Marcellian, who's the CEO of La Maestra Health Center in San Diego. She's been a real pioneer in this area. She developed her SDOH screening from the ground up when no one else was talking about it, and because she recognized the importance of SDOH data collection. So she's going to talk about implementation woes, what she's learned about IT, staffing capacity, how to build community partnerships, networks to provide services to patients. She's also going to talk a lot about how important it is, how important CHWs are in this process. And I know we have a lot of CHWs joining us today. So please don't forget to join us next time. Please join me in thanking Dr. Bethell as well as Abdeen for his case study. And we'll see you next time. Thank you so much.
Okay.
Thank you.
Bye.
Thank you
Thank
all.
you.
Bye.